So, stuttering, there's a lot of different terms here. If you look at the Moodle book, stammer was disordered speech. Now it's most often synonymous with stutter, and it's more often used in the United Kingdom, India, and Australia. Stutter is more commonly used in a number of other countries, but right now they both mean the same thing. Disfluency with an I compared to disfluency with a Y. Again, it was that typical to atypical, talking about normal non-fluencies compared to stuttering-like disfluencies. What we currently use, though, is REs, stuttering-like disfluencies versus other disfluencies. There's also a number of different terms for secondary behaviors, accessory behaviors, concomitant behaviors. So what those are the physically evident struggle behaviors associated with stuttering. So the SSI-4 calls them physical concomitants. Could be excessive facial posturing, tension, struggle behaviors, lip protrusion, eye blinking, etc., is what we're talking about there. The idea behind that is secondary stuttering behaviors are learned associative behaviors. However, they quickly become ingrained into the pattern and anticipation escape of the moment of stuttering. So you often see people using these types of behaviors in anticipation of stuttering before the moment of stuttering occurs, and you'll see their body sometimes go backwards away from the person that they're talking to. That's an indication that there is a level of awareness from the client, and that it's being used as an avoidance or anticipation to try to reduce the moment of stuttering. When you see secondary behaviors integrated within the moment of stuttering, you might see a forward proximity advancement, and that's might show that the person's saying what they want to say, they're struggling through it, but there's decreased avoidance there, is the interpretation we can make from that. I talked about between word and within word disfluencies, so in your text that's how they differentiate that. Between word are more normal non-fluencies. You see phrase repetitions, interjections, hesitations, some whole word repetitions, some pausing. Those are not stuttering-like disfluencies. However, people who stutter do present with them much more often. The stuttering-like disfluencies are, of course, the within-word ones, the repetitions, prolongations, blocks, etc. Getting back to interjections and all, quite often you'll see a client say, oh, that's just part of my speech, it's not that. And there's a deflection and justification that occurs with that. For example, I had a client who said the word 93 times in a 300-syllable length passage, and when I brought that to their attention, they were very resistant, if not resentful of that, because that's a self-taught strategy that they thought was helpful to them. However, upon showing them the video and actually having them start to count themselves and compare number of ums to actually content words or function words included, they realized how distracting it was. So it's a sensitive topic for some, but one that we should be treating too, as well as secondary stuttering behaviors as previously mentioned. We should be focusing on avoidances, secondary stuttering, overall communication effectiveness, and how to do that. As I've mentioned before, awareness is the first element of change. So people need to be aware of what's going on in order to change it and have the motivation to change it. So we often do video analysis where we present someone a video of either themselves stuttering and analyze that, or if they're not ready to that, we want to move from more temporally distant to temporally proximal. So we can show videos of other speakers who stutter talking about their stuttering. Now we can stop, pause, rewind, watch again. ultimately progressing to maybe the clinician's pseudo stuttering and the client pointing out and analyzing that, to the client video of themselves that they can pause, rewind, process emotionally as needed, gain support from the client. And then we want the client to be able to do this in real time too. So ultimately, we want them to be the active, non-judgmental observer to their own speech and be able to have decreased emotional reactivity while more effectively implementing strategies for change. In the Reardon and Reeves Horace book, they do a good job of portraying a gradient and alignment and inclusivity of fluency because normal non-fluencies are not stuttering. And as I mentioned in the Moodle book, when people say, oh, I stutter too, sometimes that does offer an invalidation to the experience of the client. Other times it's a camaraderie and inclusivity of it. So look at how they present this concept within their workbook. There's many factors, and during the pseudo-stuttering training, I covered some of this. In the sender-receiver interaction, I take a triadic hierarchy. So what the speaker is portraying and sending, what the speaker observes from the listener reactions, and then the theory of mind component too, all pre, peri, and post during interactions. Ultimately, throughout the course of therapy, we want to help clients gain knowledge and awareness of their own behaviors, and then be comfortable portraying that, advocating, setting communication expectations to others. This is accurately portrayed in Johari's window, often used within the counseling field, that you go from unknown to self, unknown to others to known to others. So that those are some of the conceptual frameworks that we'll be using throughout the class. Some of the differences, even though there's a lot of similarities in our treatment for stuttering compared to other chronic communication disorders that we commonly treat, we're not trying to cure the stuttering. Regardless of therapy type or exposure to therapy, the recovery rate for stuttering is very similar. The one exception is the lid-comb approach to stuttering therapy. However, as I mentioned before, the lid-comb approach actually excludes people who are non-compliant or deemed to be non-compliant, meaning they continue to stutter or they don't advance through the phases as quickly as they should. They're kicked out of the study, so it's really cherry-picking the data. So realistically, about 75 to 80% of the children who start stuttering will end up recovering from stuttering. We're going to get into more of that a little bit later on in the presentation. Also, do think about how Reardon and Reeves and Yaris present what we as speech-language pathologists bring to the table. Why stuttering therapy shouldn't be that scary and overwhelming, alignment to other disorders and populations we treat, ways that you as the clinician can clearly portray your philosophy of stuttering therapy, differentiating yourself from maybe past experiences that the client has had. And you want to define what successes and demonstrate a portrayal of that through a description of a scenario. You want to define the affective cognitive features, why it's okay to stutter, and how you can and help clients gain that perspective and why it's important. Think about the practicalities of these, how you would actually frame those conversations, phrase them, what's the purpose and goal, what facilitating strategies or ideas would you present to encourage that also. Most of all, we want to focus on overall communication effectiveness and efficiency. We want to help clients be more effective communicators that they can do on their terms. As Reardon and Reeves and Yaris point out, stuttering is a multifactorial disorder. We're going to get into this more in a few modules. but there's a genetic predisposition, there's environmental or maybe psychological expression of factors that maybe activate the genetic predisposition. There's neural differences, etc. Again, we're going to get into this in more detail in the future. However, I want to portray the organic nature of stuttering as being important through an analogy here. Clients, people who stutter, often feel it's their fault for their stuttering. Parents of children who stutter feel like it's something that they did, that whole refrigerator mother idea from ages ago. And Scott Palasek, a researcher in fluency disorders, someone who stutters, portrayed through voices, which is a panel presentation of people who are researchers and clinicians who stutter over the ages that have been presented at ASH, and most have been recorded and can be found on the Stuttering homepage too. So Scott Palasek portrays an experience with his mother. So growing up, he had a teddy bear. He portrayed as his only friend. He didn't have anyone else. This teddy bear meant the world to him. One day, the teddy bear went missing. More than 20 years after the fact, at a holiday, his mom wrapped up the teddy bear and gave it back to him. And Scott, taken aback, said, "Wow, I didn't know where this was. Why was it here? How was that?" And his mom thought that she had caused his stuttering and that she wanted to encourage him to have friends and all. So they had this very cathartic connection moment where Scott said, "No, it's not your fault. This is genetic. It's neurological. And Scott portrays that they both broke down crying, and that the mom described a weight lifted on her shoulders." So why I portray this is it's our job as clinicians to educate people about stuttering, fluency disorders, and to understand what they might be holding on to, and how can we alleviate them of that burden. Knowing that stuttering is not the parents' fault, but it's a neurological disorder, that there are many avenues of treatment that can lead to success and proper functioning, etc., will alleviate a lot of burden, criticality, etc., etc. There's a number of fluency disorders. We're going to primarily focus on developmental stuttering because that's the largest percentage, 1 to 4% of the world's population, and approximately 1% post-spontaneous recovery. There are, however, also acquired disorders of stuttering, neurogenic, psychogenic stuttering. There's also in about 10% of blast traumas, and neurogenic stuttering that's a little bit different too. We're going to be getting into these a little bit at the end of the course, along with cluttering and other disorders of fluency too. So just know that that's why we're focusing on stuttering right now. There's a number of interesting facts about stuttering. We shouldn't use these as therapeutic measures, but it is helpful for the clients to know and gain an awareness about. People who stutter can silently articulate or mime speech with near 100% fluency. They can whisper with 90 to 95% fluency enhancement. Talking to oneself tends to be easier. Think of communication pressure, talking to animals, talking to babies. Choral speech while talking in unison with others inhibits stuttering around 100%, etc., etc. too. We also already got into the cyclical nature of stuttering as well. I didn't know where to put this, but I think it's a good resource. There's often concern about how do I get reimbursed for my stuttering therapy treatment, and the Stuttering Foundation has a great resource on that. That's why that link's provided there. So do look at some of the myths in the Reed and Reeves Harris book. They specifically mention easy starts and slow speech not being the answer, and that's a common myth. That school therapy cannot be successful historically. School therapy and traditional therapy has not been as effective. But since we've changed and taken a more holistic approach, there's more research coming out that people who take good evidence-based practice approaches to fluency disorders in the school do have positive treatment and gains. Also know that we can take advantage of the multiple professionals within the school setting. School counselors, school psychologists, resource room individuals too. There's a number of benefits within the school setting. And also know that SLPs are creative, they're problem solvers, we know how to interact with kids, we know how to listen, we're communication specialists. So this idea that stuttering and fluency disorders are so dramatically different might not actually hold true. There's a number of factors that are present during the onset of stuttering. We see the average age of onset being about 2 years, 9 months, which it was previously thought to be, or strongly believed to be about 3 years, 5 months. We see gender differences before and after the period of recovery. We see recovery rates, as I'm going to get into soon, as the majority of spontaneous recovery will occur within 12 months post-onset. Actually, a majority, percentage speaking, is within 6 months, but really up to 18 months is when you see about 97% of the people who will recover from stuttering do so. Why this is important is from a pediatrician perspective, or the historical belief to take a wait-and-see approach. There's time frames around that. And when the individual is gaining awareness or impact from their stuttering, along with a number of other factors and signs as presented in the Reardon Reeves Yara's book, we should start therapy. We should no longer just take a wait-and-see approach. So please do know those factors. The family factor, if there's someone else who stutters within the family, especially on the mother's side, the likelihood of recovery from stuttering is a lot less. Girls tend to recover more than boys do, etc., etc. All of this prognosis information is beneficial for the parents to know, for planning treatment, for framing goals, treatment progression, etc. So this is how some of these features can be clinically applied. Something else is, we used to believe that stuttering always had a stereotypical progression, going from phrase repetitions to syllable repetitions to prolongations and blocks, awareness, impact from stuttering. However, that's only true for about 60% of the population. The Ari and Ambrose or Illinois data set illuminated a lot that we were not aware of before. So about 40% of the people who start to stutter just do so with all types of presentation, awareness, and impact also. We also see that there's a majority that have an onset within 3 days, that approximately 40% have an onset of stuttering within 3 days, whereas we used to think it took months or up to a year to see that progression occur. That's no longer the belief or reality that we live in. We will get into more of the genetics and twin studies, etc. Fascinating area. So I mentioned some of these stats before. Approximately 5%, or it could be 8 to 12, depending whose research you follow, percentage of the world's population will go through some developmental period of stuttering. All but about 1%, so about 75 to 80%, will spontaneously recover, regardless of therapy or no therapy or type of therapy, with the caveat of the Lidcombe program. So about 1% will continue to stutter throughout their lives, chronically so. There is no cure for stuttering. However, we can make dramatic advances in communication effectiveness, ability to successfully manage stuttering, reduced impact experienced, effective cognitive, etc. We also see the distribution of stuttering at age of onset. The later the onset, especially past 4 years old, even though the range might be 2 to 7, when we see an onset of stuttering past the age of 4, the likelihood of recovery is a lot less. We see a different presentation of the typography of stuttering over time. We also see the different recovery rates for people who have members who stutter in their families, or other factors presented there too. I just wanted to briefly present this and have you look through it. This is all from the RE dataset that we're going to get into a little bit more. The typography of stuttering there was presented in Bloodstein's earlier work, but it's very much also represented in Yari's and change of stuttering over time. There's a number of stages, developmental theories, etc. of stuttering. The main point of differentiation between a primary stage and a secondary stage is that level of awareness. Again, we already talked about the monster study. I'm not going to go back into that much more. But in Van Riper's, it's not only the development of stuttering, but the progression of stuttering through tracks in treatment. Ultimately, where he wanted to get clients to through mental hygiene and voluntary stuttering procedures, etc., was repetitions with little concern about their stuttering. And I'm briefly going over some of these because on your praxis exams, they love to ask some of these questions. That's specifically why I'm including them here. Bloodstein's four phases very similar. It's going from lack of awareness to awareness as differentiating, and typography of stuttering also differentiating some of the features between two. Well, that's all for now. Thank you.